Hello and welcome to today's suicide prevention webinar. Thank you for joining us. My name's Karen Lascelles. I'm nurse consultant in the Trust and I lead on suicide prevention. Today is the first of a series of 6 suicide prevention webinars, and Nick Broughton is going to introduce it in a few moments. They'll be every Tuesday for the next 6 weeks at 4 p.m. We'll be covering a number of topics, the 10 ways today. We're also going to be looking at some of the challenges around managing self-harm by ligature on inpatient wards next week. We've got a webinar looking at self-harm and suicide related to COVID, or the impact COVID has or hasn't had on that. We're going to be looking at risk assessment and formulation, the impact of patient suicide on staff, and supporting families and carers. And if this series of webinars go well, we will look to putting on more, perhaps on an annual basis, and we would be inviting interest from you as our staff to help us think about the best sort of topics to cover. So that's all that I wanted to say just now. I'm going to pass on to our CEO, Nick Broughton, who's going to chair the session for us today. Thank you, Nick.
Karen, thank you. And thank you also, Karen, for organising today's webinar and indeed this series of 6 webinars. I'm here in part as Chief Executive, but also because I'm the Executive Sponsor for Suicide Prevention in the Trust, something I've recently taken on and very pleased to do that. Not least because, stating the obvious, preventing suicide is one of the things that we really do need to focus on as a large provider of specialist mental health services. I certainly, during the course of my clinical career, have lost patients through suicide. I know of the impact that has, not obviously on the individual's family and friends, but also on the clinical team that's involved in the care of the individual concerned. And it's right that we constantly look to do what we can to improve the safety of our services and to ensure that our service users and patients who are experiencing crises are properly supported and kept safe. It's a really difficult area. It's one I know which causes a huge amount of concern and emotional distress to colleagues, and that's why I think it's great that we've got this series of webinars to reflect on some of the good work that's ongoing, but also to think about what more we can do. And one of the things we want from these webinars is to help inform our revised suicide prevention strategy, which is something that Karen is leading on. So please use the chat function today if you have any ideas or indeed questions that you'd like to pose. Your feedback, your thoughts, your reflections will be incredibly helpful for us as we move forward and look to revise and improve the Trust suicide prevention strategy. The focus for today's webinar is the National Confidential Inquiry into Suicide and Safety in Mental Health. Now, this is a unique international project that's been ongoing now for 25 years. It began in 1996. And is run by the University of Manchester. And the inquiry receives information from every single suicide that takes place across the United Kingdom and receives a very detailed data set. And from that is able to identify themes, trends, and through analysis of that, the inquiry's had a profoundly beneficial effects in helping to improve the management of mental health patients and reduce the risk of suicide. We'll be hearing in a second from Dr. Baird, who is one of the research associates working with Professor Lewis Appleby, who leads the inquiry up in Manchester. Ali's got a fantastic presentation. I've had sight of it already, and I'm looking forward to hearing from her, providing a really useful overview of some of the statistics, but also focusing on some of the key things that we and indeed all mental health providers can do to improve the safety for our patients, both in inpatient settings and in the community. So I'm pretty sure you'll find this incredibly thought-provoking. And please, as I said earlier, use the chat function to put in any ideas and questions you'd like us to address, and then we'll have a Q&A session following Ali's presentation. So without further ado, I'm going to hand over to Ali. Ali, over to you.
Ali, you're muted.
Am I okay now? Yes, sorry. I'm Ali. I'm a researcher at the Confidential Inquiry. I've been there since 2003. I'm going to talk to you now, give you an overview of some of our data from our last report, and then I'm going to talk about the 10 ways that we're going to for safer services. What I'd like to say to you at the start is please remember that I'm going to talk about data, but these are real people and these are real lives lost to suicide. Next slide, please. Next slide, please. Okay, so the suicide rate has varied over time. There have been, don't press it again, sorry. The rate has fallen since 2001 with a record low in around 2006. There was then a post-recession rise, and more recently there's been a rise in suicide again, and this looks continued to set in 2019 based on deaths recorded. The standard of proof changed in 2018, but this is unlikely to account for the rise. We know there's been a rise in young people for a number of years now, particularly young women, and also been a rise in hanging as well. Next slide, please. I'm now going to talk to you about the key findings from our last annual report. Due to the pandemic, we've had a delay in the production of this report. So this report is from December 2019. Our annual report for 2020 is actually due out in May this year, and we had to pause data collection for 5 months due to guidance on collecting data from NHS Trust during the pandemic and overburdening services. So we had a pause in data collection, and that's reflected in our report being a little bit later, but it's due out in May and with a launch in June that will be free for all to attend. But I'm now just going to talk to you about some findings from our last report just to put everything into context. Next slide, please. As you all know, suicide rates vary by area, and this also varies in NHS areas. We find the highest rates in the north and the southwest, and also in rural and coastal areas, and the lowest rates are in London and south central areas, including Oxfordshire. Next slide, please. Looking at patient suicide, there are around 1,200 to 1,300 suicides per year in patients, and that's about a quarter of the general population. Although it looks like the rates are remaining quite stable, the rates are actually falling when compared with the number of patients that are under services. Because the number of patients are increasing, the rates of patient suicide are actually decreasing. Next slide, please. Inpatient suicide has fallen over time between 2007 to 2017 with a 45% decrease. And when we say inpatient, actually only 32% of those are actually on the ward, because inpatients also include those who are on agreed leave and those who are off the ward without staff agreement and who have absconded from the ward. Next slide, please. Looking at suicide post-discharge as well, the highest risk is actually on day 3. The first week post-discharge is high risk, but the highest risk overall is day 3 post-discharge. Early deaths were associated with adverse life events and short admissions to inpatient care. Next slide, please. Also looking at crisis resolution home treatment teams now, there are actually twice as many suicides under crisis resolution home treatment teams as there are inpatients. However, this is actually a reflection that the crisis teams see the patients who are more ill, more mentally ill, including those who have been recently discharged from hospital. And also a third of those had only been under crisis services for less than a week. Next slide, please. Turning to alcohol and drug misuse and comorbidity, 54% of patients have substance misuse problems, but only a minority of those are actually under specialist services. Next slide, please. And if you just press for the things to go down, thank you. We conducted a series of studies that started in 2002, and what we did is ask services whether they've implemented certain recommendations from our Safer Services report, which was produced in 1999. In 1999, we developed 10 ways that we suggested services could improve, and we looked, we did surveys in 2002, 2004, 2006 and 2009, where we asked services whether they'd implemented certain things. So, for example, whether they had a policy on absconding or certain policies on removal of ligature points, for example. What we did is then compare suicide rates before and after implementation in specific patient groups. For example, looking at removal of ligature points, we only looked at inpatient groups, and we found that implementation of certain recommendations were associated with a reduction in suicide rates in that trust. We actually found that about 250 to 300 potentially fewer lives lost by implementing our recommendations, which also has a potential saving. Next slide, please. Using these studies and also 20 years experience of collecting data from mental health trusts, from A&E and various qualitative and quantitative analysis, we developed the 10 ways to improve safety, which relates all this to features of mental health care. Our 10 ways include safer wards, earlier follow-up on discharge, no out-of-area admissions, 24-hour crisis teams, family involvement in learning lessons, guidance on depression, personalised risk management, outreach teams, low staff turnover, and reducing alcohol and drug misuse. Next slide, please. So I'm now going to talk about these in more detail. First of all, in terms of ward safety, a huge thing at the moment is ligature points. And in 1999, we advised that services should remove all non-collapsible bed rails from inpatient wards. And in 2009, suicide using non-collapsible bed curtain rails became a never event. This means that it was deemed fully preventable. In 2017, there were 92 suicides by inpatients in the UK, and this has seen a reduction. However, there are still some suicides on the ward, as I mentioned. Looking at suicides by ligature points on the ward, you'll see between 2012 and 2014, there are about 70 suicides by ligature points on the ward. And between 2015 and 17, this number has actually reduced to 33. So this number is decreasing, which reflects all the safety prevention that has gone on, suicide prevention and safety that has gone on within the ward at the moment. Looking at this, there's suicide by ligature points from the door handle has remained about the same. Window, hook or handle has decreased. Other methods have increased, and these include, it's quite small on the screen, pipes, bed parts, shower parts, I can't even read the rest of that, towel rail, wardrobes, taps and telephones. Self-strangulation has remained about the same over time. Next slide, please. Also looking at ward safety, a huge part is safety planning for planned leave. Ensuring the ward is an area patients want to stay, including recreation, privacy and comfort. We did a study looking at the learning from clinicians' views of good quality practice in mental health care services, and clinicians emphasised practices that improve safety, such as observations should be conducted by trained staff. And also noting the increase in the first week of admission to inpatient care. Next slide, please. As I mentioned before, post-discharge is also a key area for suicide prevention, with 16% of suicides occurring within 1 week of post-discharge and 21% on day 3. So follow-up should be between 2 to 3 days of discharge. And actually the NHS long-term plan includes now 72-hour follow-up as a key area for suicide prevention. Our recommendations were also reflected in NICE guidance and the Department for Mental Health Performance Framework guidance. Next slide, please. Turning now to out-of-area admissions, 10% of patients died after being discharged from a non-local inpatient unit, which is about the same as the proportion who died within 2 weeks of discharge. Patients in an out-of-area unit are less likely to feel supported by their friends and family and are more likely to feel isolated and experience delayed recovery. A local care unit also helps with simpler discharge care planning. Next slide, please. Looking again at crisis resolution home treatment teams, as I said, there are twice as many deaths under CRHTs than there are inpatients. So this therefore has the greatest impact for suicide prevention. we did a study looking at risk assessment, and patients and carers emphasised the need for clarity about where they should go in order to seek help. Next slide, please. It's very difficult to look at family involvement because this is really down to personal experience and the patient's relationship with their family. However, what we would advise is to ask. So just ask people when they arrive at your service whether they will be comfortable with you speaking to their family, because we found that reported to us, family involvement would actually have reduced suicide risk in 18% of patients, including patients who had missed appointments. Clinicians informed us that they felt that if they could have informed the patient's family that the patient had missed the appointment, that would have helped to reduce their risk of suicide in 27% of suicides. When we examined our data to look at implementation of for information sharing with families, they were actually also associated with a fall in suicide rates. Next slide, please. There should also be a local policy for depression and self-harm. Again, when we looked at implementation of self-harm, implementation for NICE guidelines for depression and self-harm, there was a reduction in suicide rates of about 1/4. Next slide, please. All patients' management plans should be based on an assessment of personalised individual risk and not the completion of a checklist. Patients should be able to discuss where they would need additional support or things that are specific life stresses for them. Family and carers also should be involved in risk assessment where possible, and also consultation with GPs. It should really be collaborative safety planning as part of risk management and a whole system approach. Any risk assessment tools should be simple and accessible, and again, treatment should not be determined by a score. Next slide, please. Outreach teams should be providing intensive support to patients who are difficult to engage or who may lose contact, and this includes patients who are non-adherent with their medication or who miss appointments. We also found that implementation of an assertive outreach policy was associated with lower suicide rates among these, and also lower suicide rates overall. So among patients who were non-adherent, had missed appointments, but also lower suicide rates in all patients. And this guidance was featured in the Protect Life 2 document, which was produced in Northern Ireland. Next slide, please. Another point is lower staff turnover. So there should be a system in place to monitor and respond to non-medical staff turnover rates. We found that organisations with lower turnover of staff have lower suicide rates, and services with a low turnover saw a greater reduction in their suicide rates when they implemented NCISH recommendations than suicides who had a high turnover of staff. And so that was all different NCISH recommendations. Next slide, please. Substance misuse remains a key area, as over half patients with mental illness have comorbid substance misuse. There is an emphasis on joint working and an emphasis on safety, so joint working between mental health teams and substance misuse teams. Substance misuse assessment skills in frontline staff, and specialist substance misuse clinicians in mental health teams. Only a minority of patients who died by suicide were in contact with specialist substance misuse services. And when we looked at those who had implemented a policy of management of patients with comorbid substance misuse, there was a 25% fall in suicide rates. We're currently looking at a study to see whether NCISH data collection can be extended to substance misuse services. So not just substance misuse services within NHS trusts, looking at private providers as well, and charities to see if we can extend our data collection, particularly as substance misuse services are now often outsourced from trusts and our private providers. So we want to see how this changes, because we're potentially missing a lot of patients who died by suicide and are in substance misuse services that are not NHS services. Next slide, please. Thank you for listening to me. I would like to take any questions you have about our 10 ways, about our general data collection, or about the inquiry, or any papers we've published. If anyone would like me to send you a list of papers that I have referenced throughout my talk, particularly the papers where we look at implementation of our recommendations, then please get in touch with perhaps Karen, I don't know who it would be, and then I will send that list out to you. Thank you very much.
Ali, thank you so much for that. Huge amount of food for thought. I've just been scribbling down notes, a whole list of questions I'll be posing to Karen and my chief nurse and chief medical officer in due course. If I can just open up, how clear are you and your colleagues in the National Confidential Inquiry as to what extent mental health trusts are compliant with these 10 areas that you've identified as being key to ensuring patient safety and reducing the risk of suicide?
What we do at the moment is, so we haven't done our survey where we ask people. Since 2009. But at the moment we are working with NCISH, looking at different trusts who have high suicide rates and those who have low suicide rates. Actually, yourself, you were a trailblazer, I believe, as the term, as somebody who, a trust who have very low suicide rates. So an example of a good example of a trust with low suicide rates. So I believe you were one of our trailblazers on the study. I don't actually work on that study. It's my colleague Nick works with Nav and Lewis on that, and Tom from NCISH. But basically we have we've produced a series of webinars. Also, we have interactive clinics for trusts with higher suicide rates, and we send out information to them. So there's a data document which we share with them where we collate different data. We also look at, they can have phone calls and clinics and discussions amongst themselves as well about things that they've implemented which have helped, and so hopefully this is how we kind of determine this. Really, we produce a scorecard every year as well for trusts, which just shows them how many suicides there are in like nationally, then in their area, then in their sort of SHA area, and how many we would expect, whether that's higher or lower than average for what we would expect.
Ali, thank you for that. I'm now going to hand over to Karen, who I think is going to chair the Q&A session. And I see we've got nearly 130 people on the webinar, which is fantastic. So Karen, over to you.
Thank you, and thank you, Ali, for a really, really informative presentation. So just to echo what's on the chat, Ali will be hopefully sharing her slides, which we can publish on the intranet. And what I think I'll do, because I expect everybody will be interested in the publications that Ali referred to. So in addition, I'll get the list of publications and make sure that they're on the intranet in the suicide prevention page, which you can find in safeguarding, or just email me if you're struggling to navigate. Okay, so we do have some questions. I'm going to start with one from Debbie Richards, who's our Chief Operating Officer, who's asked, do you have this is for you, Ali, do you have a sense of the impact of COVID-19 on suicide rates?
Interestingly, we've actually produced a paper today where we have collected real-time data during COVID. It's not the same as our normal data collection, which I don't know if all of you know, we would normally send out a questionnaire. So we would normally get our data from ONS. They would inform us of all people who've died by suicide in England and Wales. We then contact NHS Trust to ask them if they've had contact with yourselves. If so, we send a questionnaire to the consultant psychiatrist or senior or RMO who is responsible for the care of the patient, and then we use that questionnaire to compile our recommendations and look at our data and analyse data. Obviously, at the moment, there's a lapse in when data is collected and when there's an inquest, then when that data goes to ONS, and then when we're informed about that suicide. So at the moment, we are only now receiving deaths that were in the first quarter of 2020. So we haven't received any information from that. I do know that I think there was a pause in coroner's inquests during the pandemic initially. So I think that will probably have had, that will have impacted on the suicide rate. But we have started collecting real-time data. So this is via our website, and it's a different method. However, it does look at the data across the whole of the UK, and we've published a paper today, and that looks at our real-time data collection in England during the pandemic. And what we've actually found initially is that suicide rates haven't risen, despite what kind of people have said, and despite the sort of crisis and the distress that have risen and the mental well-being of people. Suicide rates have not risen from our finding. However, that is not the same as our usual data collection, so that is not as conclusive as our usual data collection, so that must be borne in mind as well.
Thank you, Ali. On one of our webinars, so that you know, is going to be focusing on sort of the impact of the pandemic on self-harm and suicide. Professor Keith Horton from the Centre for Suicide Research, with whom we collaborate very closely, and who also collaborates with Ali and her team, will be presenting on that very issue. And I think, if memory serves me rightly, that's on the 4th of May. So we can talk in more depth about that then. And if I can just as well quickly take the opportunity to let you know, if you weren't aware, that the Thames Valley has a real-time suicide surveillance system that's been established since we started it in around about 2015-16, so it's quite established. It's grown organically over those years. So we've been able to contribute into the work that Ali has been talking about. Our system is led by the Thames Valley Police, links very closely with the coroners, the public health multi-agency suicide prevention groups, and the mental health trust, i.e. us and Berkshire. And if anyone's interested in that, then drop me a line and I can give you some more information. So Ali, whilst you're there, there's another question for you. And this one is asking, did you look at the differences in risk factors among groups with different mental health diagnoses?
Well, not specifically for my presentation. However, when we look at our data over time, we have produced papers that looks at specific diagnoses. So we've looked at papers, patients with SMI, with severe mental illness. We've looked at patients with affective disorder, with personality disorder. We're currently producing data looking at patients with eating disorders. So we do tend to look at various at different types of mental illness in terms of the 10 ways, and in terms of when we were looking at our monitoring, so before and after implementation of various factors. When we looked at that, we looked, so for example, we have I believe there was one question, I forget the wording of it, but it was looking at patients with ethnic minorities, looking at ethnic minorities and specific policies regarding ethnic minorities. And I believe when we looked at that, we, for example, only analysed suicide rates in non-white ethnicity, so before and after. So that is reflected in the 10 Ways document.
Thank you. Thank you. There's a few more questions coming through. Do the figures, this is from Steve Bell, who's one of our team leaders in early intervention service in Bucks, and it says, do the figures only include patients involved with mental health services? So I was unclear when you raised the point about looking at substance misuse service and that their figures aren't included. Yes,
so currently we only collect data from NHS trusts in England and Wales, so only those it's specialist mental health services. However, we did a feasibility study where we looked at extending that to see if we can collect data from private providers of substance misuse services and charities, etc. Just because we used to, obviously, substance misuse services used to be provided by NHS trusts, and now they're no longer. So we wanted to look to see basically the population that we're missing, and it was something that we were asked to do, to see if we could do that. So we looked to see whether it was feasible. We think it is, so we're now trying to extend that out to look even closer and to try and start basically start the study, if it is possible, to start that to see looking at specialist substance misuse services. But at the moment when we're sort of talking about patients who have died by suicide with mental illness and have comorbidity, we only know about basically the questionnaire when somebody's answered, the clinician completing the questionnaire has answered that they were in contact with substance misuse services.
Thank you. I think that will be very welcome work, so good luck with it. There's a question here around that I think you've answered from an anonymous, the reduction of suicide rates. Is this anything to do with reporting reporting and an increase in a narrative verdict by the coroner?
So the standard of proof was changed in 2018, but we don't think that it will account for all of the increases, just because for a number of years we've seen a rise in suicide by young people, particularly in young females, and also there's been an increase in hanging for a number of years as well. So while we think it potentially could have a slight impact, we don't think it will be responsible for the full increase now.
Thank you. We've had two questions around assertive outreach. I think sort of one's for you and probably one is for Nick to think about and maybe come in a bit. So the first one, I'm interested in the outreach work that you detail as one of the 10 ways to safety. Is this the traditional assertive outreach model, or are there other forms of community outreach interventions? And linked, for Nick to think about, are there plans to reintroduce assertive outreach teams in BUCS as well as the crisis home treatment teams?
Specifically, I'm talking about CRHTs when I'm speaking, just because that's information that we have collected. So I'm specifically focusing on CRHTs. But obviously, as I've said, these are key areas for suicide prevention at the moment and a key suicide prevention priority.
Thank you. Okay. Gosh, they're coming thick and fast now. Sorry, Nick.
George, coming. So I must admit, I think we do need to look at whether we want to reintroduce assertive outreach teams. When I was down in Hampshire, we had an assertive outreach team which works in Southampton, and I think was pretty successful. And if you look at the benchmarking data that's produced by the National Benchmarking Club and some of the challenges we face compared to other provider organisations in terms of bed occupancy, etc., there is a reasonably compelling argument that we need a more assertive approach to managing patients with complex long-standing needs, particularly chronic schizophrenia in the community. So I do think that it's necessary to revisit the assertive outreach question, and therefore we may, in some point in the future, look to re-establish that model. But obviously, we would need commissioning support to do that.
Thank you, Nick. And whilst you're there was another question from Lloyd that's more directed to you, I think, regarding encouraging family involvement in supporting service users with missed appointments, etc. If a service user agrees, can this work against a service user engaging more fully themselves in the support they are being offered?
I didn't quite follow that, Karen, I'm afraid. Sorry.
So if a service user agrees that we can encourage family involvement, I think the question is, might this work against, I guess, service user autonomy, I think is the question. Can this work against a service user engaging more fully themselves in the support they are being offered?
Yeah, I suppose my thoughts are that this needs to be done on a case-by-case basis. Clearly we want to work with the service user and get his or her agreement to work with the family. What I would say, if you look at our serious untoward incident reports, not just here but in any trust in relation to suicides, often you'll see there's an issue in relation to information sharing with the family and concerns by the family that their thoughts and views about the patient were not taken into consideration and into the care plan. And I think we probably haven't got the balance right at the moment, and we are too cautious and afraid of breaching patient confidentiality, but therefore undermine the quality of care that we could be providing if we engage more fully with the patient's family. I personally think we need to sort of recalibrate this. And that's why I'm very keen that we roll out the triangle of care model effectively across the organisation, because that does really reinforce the importance of working in collaboration with carers and family in supporting our patients.
Thank you, Nick. Yeah, I echo that, and certainly something I'm very passionate about. And in my clinical work, when we can work effectively with the individual and their family, I think that that's the best quality care that we're able to give. So I think triangle of care would be great. And we have got one of our webinars will be focusing on supporting families and carers in a few weeks. I think that one is the 11th of May. Going by memory. Thank you. Okay, another couple for you, Ali. I'm going to combine them. The first one says, have you looked at links with domestic violence and suicide within the patient population? And the other one is around young people. Have you evaluated factors contributing to increase in suicides in young people? So 2 questions there.
Yeah. So first, domestic violence. No, we haven't particularly looked at this. I understand that I've seen recent reports actually about this, and that potentially being a victim of domestic violence can increase suicidality. So it's a question we do ask. So we do actually ask whether a person has been in the advert. We have a section about adverse life events. So we ask about in the 3 months before death, was the person a victim or perpetrator of violence, and that includes domestic violence, and we separate that out as a category. And then separately as well, we now ask, which is a more recent introduction, I think probably 2-3 years, we now ask specifically, had there been a victim of any domestic violence over their life course. I'm currently working on a paper looking at female suicides, particularly focused on that, and I did actually look at that variable the other day. However, it's not coming up as anything at the moment, but I think that's more, again, because the question is more recent. So I think we only have more recent data on that. So because of that, it's not something we've particularly looked at or focused on before. In terms of young people, we actually produced, we looked at a study on children and young person and the antecedents of suicide by children and young people. And for that, we looked at various factors. So we actually got coroner's reports and the SUI reports, and we analysed different things to do with that. There's a report and there's a couple of papers already about that as well, and I'll include that in the list that I sent to you, Karen, about the literature. And we looked at that, and there's various factors that were associated by suicide in young people who were not in mental health services, and these include things like bereavement, social media, exam stresses, work stresses, sexuality, that sort of thing. So that was something that we found were stresses for young people.
Thank you. Thanks, Ali. And the one last one for you, I think, is come from Ben. If I've got the right Ben, is from our crisis team in Buckinghamshire, who's asked, would the lack of limitations to accessing means be a contributing factor in the increased rate of suicide within crisis teams?
Do you mean so being unable to access crisis services when in crisis?
I suppose I'm interpreting it is about accessing the means that the patient or service user may have, the method for suicide, that if we're not,
okay.
I suppose that there's probably a double-pronged question. Is it, some of it might be to do with our means reduction sort of interventions, and some of it might be around the ability to go into somebody's house and remove means, I'm guessing, but I suppose he's asking, has that come up, that difficult?
No, we mainly look, obviously hanging has been a method that has increased over time. We've noticed an increase in hanging, and certain methods do change. For example, carbon monoxide poisoning used to be a method of suicide, and now is not so much a method of suicide, just due to environmental factors and catalytic converters on cars. So we don't find that really now as a method of suicide. However, other methods of suicide are now methods that appear on our database that were not there before. So things change, and obviously hangings increase. So it's not something we particularly look at. We obviously have looked at inpatients, and our report this year, which comes out in May, has a section on inpatient suicide by ligature points, and we focus on hanging and strangulation. However, we haven't really looked at particularly, for example, methods within CRHTs, for example, but it's something to look at.
Thank you. Thanks. Thank you very much, Ali. And then I think there's one more question for Nick, which is around how is the Trust planning to address the high staff turnover, particularly in the adult mental health teams, considering that this potentially impacts suicide rates?
It's a great question, and when I saw that slide that Ali presented, it obviously got me thinking. The last thing we want is people to be leaving our services, and not least because of the importance of delivering continuity of care. It comes down to Oxford Health being a great place for people to work, and I've spoken about this frequently during my time as chief executive. We need to have the right culture. We need a culture that supports people. We need to be an organisation that cares for our staff. We need to be an organisation where people can progress their careers, where people feel they're being recognised for the work they're doing. If we can achieve that, we will retain people. We won't therefore have high staff turnover. We'll be able to deliver better care to our patients, and therefore, as Ali's demonstrated, we should be able to reduce the likelihood of our patients taking their own lives.
Thank you. And one more question, which I'll take actually, that's just come in until it was closed. This is from Linda Thompson, who's a peer support worker in our crisis home resolution treatment team in Oxford. Hello, Linda. And you asked about, a couple of years ago, I did a study with the suicide group on families. There was no support from anyone that was left behind after suicide. Has something been put in place now? And yes, it has. We have a family liaison service up and running now, and we will talk about that in a bit more depth in a few weeks at the webinar that focuses on families and carers, so do tune in then. So this brings us quite neatly to the end of our webinar. Thank you very much for being here. I hope you found it informative and useful. Please do think about tuning into the forthcoming webinars over the next few weeks. If you can't, they will be recorded and available on the intranet. And I guess just one last thing I'd like to reflect on is, I'm in my position, I'm really privileged that I work with staff across the organisation. I meet an awful lot of you in training or in other fora, and I'm consistently impressed and humbled by the commitment that everybody has to their work and their patients and suicide prevention. And as well as us learning from the incidents that tragically occur, we need to learn from all of the good work that we do. And we really do welcome your thoughts and perspectives on what you'd like us to prioritise in the suicide prevention strategy, any learning you'd like to share, and any ideas that you have for improvement. So you know where I am, drop me an email anytime, and I'd be really, really pleased to hear from you. So thanks very much. And thank you, Ali, very much indeed. And thank you, Nick, for chairing. And I look forward to seeing, hopefully, many of you next week. Bye-bye. Are we finished?